the next president ready, keep it ready. So inauguration panel.
Okay, sir. Okay. Good evening, everyone. In the 4C series, this is the second episode which we are having today, which is going to concentrate mainly on a child with a lip. Before we start the program, I now request our treasurer, Dr. Dakshani, to say the pediatrician's prayer, please.
Dakshani, ready?
Yes, sir. குழந்தை மருத்துவனின் இறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணியுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர் தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தனவற்றை மாற்றோம், நல்லவற்றை உள்வாங்கோம், மாற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்ளோம், போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். தேங்க்யூ. தேங்க்யூ சார்.
Thank you, Dr. Dakshani. May I now request our President, Dr. Suresh Balan sir, to say President a few words.
Very good evening to all. Secretary Dr. Tirumurugan, Treasurer Dr. Dakshani, all the office bearers of our state IAP TNSC, the executive board members, the central IAP members, Dr. Viswanathan sir, Dr. Janani Shankar, and the coordinators for this great event of IAP TNSC under the Presidential Action Plan. That is the 4C series. Dr. Ashwath and the academic coordinator, Dr. Rajendran sir, and all the experts who have joined today, Dr. Suma Balan, Dr. Sangeeta, Dr. Lenin Babu, Dr. Kannan, and the various presenters. Gives me immense pleasure to welcome you all for this wonderful event, which is aimed at enriching the knowledge of all the practicing pediatricians over the state. And I should really appreciate Dr. Rajendran for taking up this initiative, along with Professor Dr. Ashwath. And the last one, which was held 2 weeks ago, was a great success, Fever with Rash. And the discussions and the presentations were very high standard, very useful for all the participants as well as the viewers. So even today, I think we have got a good number of viewers, and all the panelists, extremely well knowledgeable panelists are here. And so I think today's topic also, the limping child, is a very important topic. And so I think it will be useful for all. I take this opportunity to welcome and thank you for this thing, and I wish the program a great success. Thank you.
Thank you very much, sir. Let me now call upon the coordinator of the Academy of Pediatric Sciences, IAP TNSC, Professor K. Rajendran sir, to take over the proceedings and start the 4C series for today.
Thank you, our Secretary Dr. Tirumurugan, respected our dynamic president, under which we are doing all the IAP TNSC, the academic of pediatric science work, and I think we are doing a lot of academic work on pipeline. One is we have started a postgraduate teaching program alternate days, and as well as 4C series, and the next one is we are going to have a foundation course also, and fourth one is we are having IAP journal also. And this thing, I really appreciate our President Dr. K. Suresh Balan has given immense support and help to do this program all over Tamil Nadu. And I really thank our Honorary Secretary Dr. Tirumurugan who has helped us making this possible. And I thank President-elect Dr. Balashankar and Dr. Dashani, Treasurer, and all the central as well as state EB members, and our program convener Dr. Aswath, and he is doing immense support, and as well as he is meticulously preparing all the presentations with the help of other presenters. And Really, on behalf of IAP TNC, we are thankful to all the delegates and as well as faculties who are here. And I really thank experts today, Dr. Suma Balan and from Cochin, and Dr. Sangeeta, and as well as Dr. Lenin Babu is currently is a consultant pediatric orthopedic surgeon at KMCH, and Sangeeta, everybody knows, and she's a professor of pediatric neurology at CMC Vellore. And Dr. Kannan is much more interested in pediatric radiology, and so there are 4 expert stalwarts are there, and I think they will do a much better work for our whatever the issues we are having. And we are having today is 6 presenters, and from Dr. A.K. Jalil Ahmed and Dr. Nilofer and Dr. Karthik, and as well as Manu, and Dr. Jaysri Aswath and Dr. Arun Kumar. And this few words I will ask Dr. Aswath, please take over.
Thank you, Dr. Suresh Balan sir, Tirumurugan sir, and Dakshani, and Professor Rajendran. We are indeed overwhelmed by the support the 4C series has received in the first outing. We had some teething trouble in the first presentation, so we have decided to cut down on the number of cases and have more expert inputs, and we are indebted to all our esteemed panelists. Dr. Suma Balan is Professor of Rheumatology. She's a pediatric rheumatologist at Amrita Institute of Medical Sciences and my senior at JIPMER. And then we have our erstwhile colleague, Dr. Lenin Babu, who's a pediatric orthopedician from Kobe Medical Center, who's also doing a lot of philanthropic work for education of children in rural areas. He's been single-handedly championing that cause as well. And we have Dr. Sangeeta, very mature brain on very young shoulders, Professor of Pediatric Neurology at CMC Vellore, and Dr. Kannan, who's ever enthusiastic and happy to share his knowledge. He's a pediatric radiologist. Without further wasting time, I would like to have the first presenter. If Dr. Jalil is ready with this presentation, we could set the ball rolling. We wish a pleasant evening and a happy learning experience for all concerned. Thank you.
Dr.
I don't think Dr. Jalil has joined it. I think
So
we can move on to the
next. Yeah.
Perfect.
second. May I request the presenters to stick to the time, please, so that we can finish it on time. Thank you. The second presenter for today is Dr. Nilofer, isn't it? I think she's there.
I think Dr. Manu is there. I think you can ask to start with Dr. Manu.
So Dr. Nilofer is also here. Dr. Nilofer?
Sure.
No problem. Otherwise, Dr. Manu is there. Yeah.
Yeah, we can start with Dr. Manu also, if that's okay.
Yeah. Manu, you can start, please.
Thank you, sir. Thank you.
Yeah.
Thank you for this opportunity.
Manu, you can go for a slide share mode now, please.
Dr. Thiru, you can start moving the slides.
Yeah, it's okay. Okay.
He is doing it himself. So
Yeah, Manu, can you hear me?
Yes, sir. Yes, sir. Hello.
yeah, please proceed.
Sir, thank you for this opportunity, sir. I am Dr. Manu, DNP PG resident, Krishna Hospital, Tirunelveli. Sir, today, this is a 13-year-old female girl presented with the pain over the left hip for the past 20 days with the difficulty in walking. So, sir, going for the history of presenting complaint. So, the patient was apparently normal 20 days back. Then she developed pain over the left hip, which was insidious in onset, which increases in intensity over the previous 3 days, and with refusal to bear weight on the affected leg. The pain was not radiating in nature and not relieved on taking medication or rest. There is a history of trivial trauma is there, and there is no history of fever, anorexia, weight loss. There is no history of associated abdominal pain or back pain. No history suggestive of any other joint involvement. And also there is no history of neck pain, visual disturbances, no history of contact with the known case of tuberculosis, no past history of measles or tuberculosis, no history of numbness or altered sensation over the limbs. Sir, then coming to the clinical features. Sir, general examination, there is no pallor, no stress, no clubbing, cyanosis, lymphadenopathy. And the vitals are patient was febrile and the BP was normal. And coming to the anthropometry, weight was 65 kg on 93rd percentile, and height was 156 centimeter, 42nd percentile, and BMI was 26.7, which comes under overweight category. And coming to the systemic examination, locomotor system, the examination of the sacroiliac joint, the Faber maneuver is positive, which is ipsilateral hip is gently flexed, abducted, and externally rotated, so that foot is placed over the opposite knee. So this positive Faber is that is associated with the reproduction of pain at the sacroiliac joint in the upper inner buttock region rather than the lumbosacral, trochanteric, or groin region. And the sacroiliac compression test is positive. Examination of the hip joint is normal. Examination of the spine, knee, and other major joints are essentially normal. And going to the CNS examination, the higher function, speech, cranialness are normal. Motor system, there is no wasting, power, tone, superficial reflexes, deep tendon reflexes are normal. Other systems are within normal limits.
Dr. Manu, can we take a break here and have the experts' input, please?
Okay, sir.
Dr. Lenin?
So a 13-year-old girl, slightly overweight, spontaneous onset of pain in the left hip, unable to weight bear, difficulty in walking. So any kid presenting with a hip pain beyond the age of 10, only 2 or 3 conditions that come to the mind. Okay. The number one from the orthopedic point of view, what we would like to actually rule out is a case of SCFE. SCF is slipped capital femoral epiphysis, or SUFE, we call it as SUFE, slipped upper femoral epiphysis. This comes on the top of the differential diagnosis for somebody presenting with a painful hip between the ages of 12 and 14, because that is the place, that is the age where the slipped capital epiphysis takes place. Okay. Of course, from the clinical examination that you have made, that the hip looks completely normal, and you said that there is tenderness over the sacroiliac joint, and the Faber's test is positive. Faber stands for flexion, abduction, external rotation, which suggests maybe an underlying sacroiliitis with some sort of inflammatory arthritis that has led to sacroiliitis. And of course, irritable hip and septic arthritis are the other differential diagnosis that you have to keep in mind. But the examination, clinical examination, as well as the biochemical markers and other things, that doesn't suggest anything to suggest that there is a case of septic arthritis. So the top of the differential diagnosis still, I think, will be, you have to rule out a case of slipped upper femoral epiphysis. But considering the fact that the patient's hip examination is normal, there is actually Faber's test is positive, your diagnosis will be more a case of sacroiliitis, secondary to some inflammatory conditions like ankylosing spondylitis or Reiter's disease, especially in girls. But proper X-ray is needed. So you need to send some blood investigations in the form of complete blood count, ESR and CRP, and go by the coach's criteria to rule out any septic arthritis. That will form a baseline investigation. On top of it, a simple X-ray of the pelvis will give a lot of clue as to whether the patient has got slipped upper femoral epiphysis, especially ask for a plain AP of the pelvis as well as a frog leg view. Most of the slipped epiphysis are actually picked up on the frog leg views rather than a simple AP view. And
sorry for interrupting. Can you please tell us what is the age-wise differential diagnosis for hip pain? Because it's a 12-year-old child, you said you would keep SCFE or SUFE as your first diagnosis. Suppose it was a 5-year-old child, would we still need to consider SCFE, or would the age decide the differential diagnosis?
Okay, so to make it simplified, to simplify the painful limb, what we say is from 0 to 5 years, the top differential diagnosis will be either an irritable hip or septic arthritis. So those two will be the top of the list from children between 0 to 5 years. From 5 to 10 years, Perthes disease, because of the unique blood supply and the amount of intracapsular constriction of the medial circumflex femoral artery, for some reason or the other, blood supply to the femoral head tends to get obstructed between the ages of 5 to 10 years. And for children above the age of 10 years, SUFI or slipped upper femoral epiphysis, because of the weakness of the perichondral ring, causes the slip to happen in the epiphyseal region. So 0 to 5 years, irritable hip or septic arthritis, you have to rule out as per the coach's criteria. 5 to 10 years, Perthes disease will be the top on the list. And beyond the age of 10 up to 16, slipped upper femoral epiphysis for various reasons will be the top of the differential diagnosis.
And Dr. Annan, would you please tell the audience what a frog leg view is and what does it show extra that a plain X-ray would not show? Your inputs on that, please. Dr. Kannan?
Yeah, yes, sir. The frog leg, as sir told, it's mainly for that SCF, like that epiphyseal displacement. That AP, it won't show that much that posterior displacement. That frog leg only shows that medial and that posterior displacement of that SCF. That's what the advantage of that frog leg views.
So frog leg view will better delineate the anatomy for all hip pathologies, or particularly for slip capital femoral epiphysis. Is this specific for this disease, or in any hip pathology, you would want the pediatrician to take 2 X-rays, one plain X-ray and one frog leg view? Is that the lesson we want to get back home? Any hip disease, should we do a frog leg view? That is my question.
Actually, Lin sir want to.
Yeah. So what I would say is for children less than 10 years, the chances of SCF is very less, because the frog leg view is more useful to rule out a case of SCF than anything else, because we do some measurements on the frog leg views. And the advantage of frog leg views is nothing but a lateral view of both hips in a single film. So instead of, it will be easy to compare one hip with the opposite normal hip. Most of the time, the SCF happens unilaterally on one side only. So we measure the Southwick angle on one side and see what is the normal Southwick angle on the opposite side. So a frog leg view is a fantastic lateral view of both the hip joints, showing both the hips in a single film. With one shot, instead of taking 2 separate and trying to paste together to see what is Southwick angle on this side and that side, finding out the SCF on this side. And so it's a simple AP view of the pelvis, and a lateral view is the frog leg view, which shows both the hips at the same time. It's easy for us to do all the measurements and compare it with the opposite side.
Thank you, sir. Dr. Suma, would you consider any rheumatological condition in the differential diagnosis at this point of time, or is 20 days history too short a period to consider a rheumatological illness?
20 days is actually, I need a few more answers here. From the history point of view, is there a diurnal variation in the pain? How is the child sleeping? Is there night pain? Or is there early morning stiffness when the child wakes up? Is there difficulty when the child is trying to move in the bed? Is there a difficulty in turning in the bed when she's trying to sleep? Because these are all things that can also suggest an inflammatory cause of the what looks like sacroiliitis here. The examination with a Faber positivity suggests that either we are dealing with inflammation of the sacroiliac joint, or we are dealing with some enthesitis around the sacroiliac joint, various ligaments attached there. Now, in a 20-day period, I wouldn't call this a JIA yet if this is the very first presentation that the child has. However, I would definitely consider a possibility of a reactive arthritis. So I would therefore ask.
Faber test is, Dr. Suma? Can you please elaborate the implications of a Faber test positivity?
A Faber test is specifically done for the sacroiliac joint. But the caveats are that if you have inflamed hip or knee or something, you can get, because you can get those joints also tender. So it's the way you interpret the test has to be very, very correct. The patient can complain of pain if there is pain around the knee as well, though they will localize it to the knee, and you have to make sure you're not confusing with that aspect. Here, the thing is they have done 2 tests for the sacroiliac joint. They've said sacroiliac compression is also positive, and they have said a Faber is positive. So it looks like the child has inflammation of that side sacroiliac joint. The other possibility is the child could have one of the enthesial attachments to that sacroiliac joint could be inflamed. And enthesitis, rather than joint itself being inflamed, the findings can be quite similar in a clinical presentation.
So if I understand you correctly, a Faber test positivity is sensitive for sacroiliac involvement, but not specific for it. Is that a valid assessment?
Yes, it's not specific for it unless you know how to interpret the test very correctly. There can be confusions in the interpretation if the patient has other joint involvement as well.
Okay, right. Thanks for those inputs. Dr. Manu, can you get on with the...
Ashwath, can I? So in the Faber's test, once you put the leg into flexion, extension, abduction, and external rotation, the patient has to specifically point the pain towards the sacroiliac joint. They will point the finger towards a specific joint. So if the pathology is in the knee or in the hip, they will point at a different place. But if the pathology is confined to the sacroiliac joint, and once you put the limb in flexion, abduction, external rotation, the patient will specifically point the finger towards the sacroiliac joint. So by that way, you can actually, in one sense, rule out problems happening in other joints.
Absolutely fantastic. Thank you. Thanks so much for that input. Dr. Manu, can you continue with your presentation? Investigations,
Investigation part. Hemoglobin 10.8 and total count 8,550 and platelet 6.3 lakhs, CRP 43, ESR 100, RFT normal, LFT normal, urine routine, chest X-ray normal. Then ANA profile and RA factor was negative, HLA B27 was negative, and peripheral smear was normal. Sputum CB net was negative. And coming to the MRI.
Before we go on to the MRI, can Dr. Suma Balan please clarify whether an ANA and a rheumatoid factor test would be justified in such a short history?
Definitely not. I think even a HLA-B27, unless you have a good long history or a history of, say, psoriasis or similar disease in the family or something, I wouldn't rush to do it at this point in time. As I said, my first diagnosis here the important thing, there are 2 things in the history he brought out. I mean, the history of inflammatory arthritis is not brought out in the history because he has not mentioned whether there is early morning stiffness and things that I mentioned before. There's a very important point, but he said the child is not bearing weight at all. That is very important because with inflammatory arthritis, it's unusual that the child will absolutely not walk. They can be, they can be very, this thing in the mornings, when they wake up, they can find a lot of difficulty in bearing weight, walking, etc. But after time goes on, they are able to do so. Whereas here, the child is completely off her feet by the history that I listened to him. And that is important because that history would definitely make me do an MRI in this scenario.
And would the CRP and ESR of 43 and 100 respectively, would that be a dampener on the diagnosis of SCIFI? Would it point towards an inflammatory pathology?
Definitely. I agree with Dr. Lenin that when a child comes to you with this kind of history at this age, slightly overweight, definitely SCIFI has to be top in your differential diagnosis because it is something that is so important not to miss. But at the same time, the findings here are so clearly towards sacroiliac joint and around it. And so our differential comes down to either an acute disease of the sacroiliac joint or a reactive arthritis of the sacroiliac joint, or an enthesitis process around the sacroiliac joint. It can be the early phase of a chronic inflammatory process. That time will tell, follow-up will tell. If the patient's family, there is a history of psoriasis, there are changes of psoriasis in the child, this can be the earliest presentation of psoriatic arthritis as well.
Okay.
But this, with the story that the child is not weight bearing, I would go for an MRI in this child.
Okay.
And ESR CRP only suggests an inflammatory process. It does not distinguish between infection and inflammation at all.
Okay, thank you. Dr. Manu, now you can proceed with your MRI and wrap up the case. Dr. Manu? Yeah.
For MRI lumbosacral spine with both hip joint shows, there is subchondral marrow edema noted in iliac and sacral side of the left sacroiliac joint. There is minimal fluid with erosion noted involving the left sacroiliac joint. There is edema that also noted in the left posterior paraspinal muscle at L3 to S1 level. There is mild edema of right gluteus medius muscle, noted posterior to neck of the femur region. So that features suggestive of acute left infective sacroiliitis with the abscess formation.
Very good.
You can proceed, Dr. Manu. You can wrap up the case. You can tell us what you did and what you plan to do for the child.
We did CT guided left sacroiliac joint aspiration. The FNAC report, the smear shows scattering clusters.
Proceed, Manu.
Voice is breaking.
That smear shows scattered clusters of epithelial cell with oval nuclei and indistinct cytoplasmic borders, with dense clusters of reactive lymphocytes and many scattered neutrophils in a necrotic background. The FNAC report suggestive of a granulomatous inflammatory pathology with suppurative degeneration. A cold abscess.
Next slide, please.
Okay. Go ahead, Manu.
What about your cultures?
Cultures were sterile.
Just we've gone through,
Okay.
Dr. Manu. Can you go back? Can you proceed?
Go. Proceed, Manu.
Proceed. You're going forward. Yeah.
Okay.
Next slide, please.
Next slide.
The differential diagnosis.
No. Just we've gone through, Dr. Manu. Can you go on to the next slide, please?
Next slide, please.
Is it, sir? Hello.
Yes,
Okay.
please go
You're
ahead.
audible. You're audible.
So the diagnosis is left sacroiliitis due to tuberculous etiology.
Yes.
Would this history be comfortable? Are you happy to have this diagnosis of tuberculous etiology?
Sir, this is actually very, very unusual to have tuberculosis involving a sacroiliac joint, but we have to keep infection on the top of the mind apart from SCFE and inflammatory arthritis. So sacroiliitis, most of the time, especially a pot spine, it starts in the thoracolumbar spine and it tracks down along the iliopsoas and it comes all the way up to the lesser trochanter and presents as a psoas abscess from time to time. And when we look into the MRI scan, we will see that the pus has been traveling all the way from the thoracic spine, lumbar spine, and along the iliopsoas, it touches the sacroiliac joint. And sometimes it comes all the way down and presents as a swelling at the level of the lesser trochanter. So we have seen quite a few cases where we surgically drain all the way from the thoracic spine up to the lesser trochanter. So this presentation of sacral or tuberculosis just confining to the sacroiliac joint per se is very, very unusual. It's worth noting down that infection could be one of the differential diagnoses in cases of sacroiliitis. So very unusual. Okay.
Since it is from my place, I had to intervene. Sorry, Dr. Ashwin. And there are, sir, due respect to the experts here, we are very poor in the examination of the locomotor system, we have to confess. I think the better bedside thing is to follow the GALS thing, that is gait, arms, legs, and spine. Suppose you make it as a table and it should be easy. And also there is a mnemonic called WILDA.
That is the words, how they say the pain is, what is the intensity of the pain, what is the location of the pain, what is the duration of the pain, and what are the alleviating factors, what are the aggravating factors. Suppose you go by that, clinically itself we can make. And if you grade the arthritis, with due respect to the orthopedic surgeon here, there are two things in the pediatric practice which could be grade 4 arthritis, namely the rheumatic fever arthritis, which the patient won't allow you to touch. And the second probably is the septic arthritis. This child was not acutely ill. He said there was no fever and the child was not acutely ill. And also the blood criteria, the CBC and all, they do not suggest an acute etiology. So the aspiration showed granuloma testing and the HPA, it shows the presence of tuberculosis. I do not know whether it tracked down for the upper thoracic spines or something, but the other spine examination, the MRI screening at the other spines were normal. So we were forced to localize on the sacroiliac joint, and this was a rarity. That's why the case was presented.
Thank you. Thank you for your inputs, Dr. Raju. And so can we have just one slide, or can you just tell Dr. Manu what we did with this patient, how the patient sat?
Sir, we started on ATT as per the guidelines, and that showed symptomatic improvement on follow-up.
Wonderful, wonderful.
Go to the next. No, go to the next slide. Oh, okay.
Sir, we started on ATT, and that showed a symptomatic improvement on follow-up, and we completed the full course of anti-tubercular drugs. And MRI at the end of the therapy showed residual stages.
Thank you, Dr. Manu, for that wonderful case. You did a wonderful job. Thanks, panelists, for their inputs. Can we go on to the next presentation, Dr. Thiru? Thanks, Dr. Manu. That was well done. Thanks, Dr. Raju, for your
Can
input.
I just say one thing,
Thank
Dr.
you.
Ashwin?
Yeah.
In this scenario, I would consider brucellosis as well as a possible etiology, especially with sacroiliitis. It is one of the infective agents known to cause sacroiliitis.
Point taken.
And it can present just like this. You can get granuloma on histology. So that is something that it can be a differential diagnosis.
And rifampicin works for brucellosis as well.
But will it respond to ATT, madam?
Rifampicin, yes.
Rifampicin works very
Rifampicin.
well for brucellosis.
Rifampicin, yes. Long-term rifampicin. Okay.
Yes.
Thanks. Dr. Jalil, are you ready with the presentation, sir? Can we start?
Ashwin, sir, there was a question from Dr.
good evening.
Suresh Balan saying, was CBNAAT done on the aspirate? What does it mean?
CBNAT is cartridge-based nucleic acid analysis testing, sir. That's basically molecular testing. PCR for mycobacterium tuberculosis.
So it's
Molecular test for microbacteria.
Okay, okay. Thank you, thank you.
Thiru boss?
Yeah.
Thiru,
I'm here.
can you please share my slide?
Delhi sir, you are audible. You are audible.
Dr.
In the meantime,
Yes.
in the meantime, good evening, friends, senior teachers, and my respected experts, and my dear students. I thank the IAP Tamil Nadu for giving this opportunity, and I thank Ashwath and Rajendran for allowing me to present this case. This is a very simple case, which I have noticed a couple of days back. So this is a 2-year-old boy with having the history of self-fall 10 days back, not noticed by the parents. He came to the casualty with pain and swelling of the left knee and inability to bear the weight. And this child, of course, consulted the nearby hospital where the routine symptomatic treatment was given. So this baby complains of pain, swelling, and reduced range of movement left knee, unable to straighten the lower limb, difficulty in squatting and sitting in the crossless position. In the past history, there is no significant trauma, no constitutional symptoms, no similar complaints in others. History of trivial trauma, that is fall in the bathroom 10 days back, but did not have complaints immediately after that. So, clinically, this is a baby afebrile, the vitals are stable. Local examination, patient lying on the bed, but refusing to be brought on the floor. we notice an acute limping, massive effusion, mild warmth, tenderness, and the knee range of movement is around 40 to 90 degrees. So with this, we investigated. This is actually on admission. The count is 7,750, and the ESR is 20, and the repeat ESR is 12 mm. CRP is 5, and the repeat CRP is 1.22. Other tests like a blood culture and urine culture as normal. And CT scan, we tried MRI, we could not pacify the child, so we just rushed for only the CT scan, which revealed the soft tissue edema. So this is the video of the child. See, there is obvious limping of the left knee, very painful condition. So this baby, the baby was assisted by the elder sibling. Next video. Obviously, the baby is not landing. Usually, in the clinical examination, we have to observe the child while walking, whether the baby is on a toe walking or the landing on the heel or the other painful condition. This is actually the local doctor has put a small splint. Even then, the child restricts the movement of the left lower limb. This is a final this thing. So next slide.
Dr. Sangeeta, Dr. Jalil, can you please pause your presentation for a while?
Yeah. I'll pass
Dr.
it down.
Sangeeta,
Yes, sir. Yes, sir.
sorry for not including you in the first case definition because there was a little of neurological value. Can you please tell the audience what we mean by a limp in the first place? Please elucidate the meaning of limp for a pediatric neurologist. Would it be the same as an orthopedician? 2, is any child who is refusing to bear weight on a limb for whatever reason, whether it's pain or genuine muscle paralysis, would this child qualify for a classification of acute flaccid paralysis? Is this a notifiable case? What are your thoughts, please?
The first question is the definition of limp. Limp is a deviation of a gait pattern from the normalcy for child's age. So that we define it as a limp. So in this particular patient, he has developed pain in the left knee joint following a trivial trauma, and there was no associated weakness. So the limitation of activity was basically related to pain. Basically, it is and he has a limitation of difficulty in bearing weight and walking, due to that which we can classify as an antalgic gait rather than a weakness. So this child, and a neurological examination, does he have any deficits, sir? Does he have any motor weakness or any loss of reflexes or any sensory loss?
During the initial examination, thoroughly looking the child walking as the baby entered into my clinic, we have to do the complete thorough physical examination along with thorough neurological and examination of the muscles and the joints. Obviously, I don't find any neurological illness or tenderness in this child. So the initial CT, they have concentrated on the calf muscle and the knee joint. I mean, the left ankle joint. It didn't reveal any positive findings. So the pain, because the pain persists, they approached me, and I thought the problem is not the ankle, not the hip. It was focused to the knee joint because obviously there was a swelling.
And his tone was also normal. Tone was also normal. Reflexes and power examination was also normal.
It's normal. There is no length discrepancy. Muscles are all right. And the baby, except for the acute limp triggered by self-fall, and the baby had some other treatment like massaging, that has triggered
temporary.
Sure. So in this child, there is no definite neurological involvement because there is no weakness and there is no sensory signs and there are no dropped reflexes in hyporeflexia or areflexia which is observed. And so we cannot classify this under an acute flaccid paralysis, sir.
Thank you. Thank you, ma'am. Dr. Kannan, can you tell us what would be the best investigation to do for a child which is cost effective? Will an X-ray of the knee be in order? Will ultrasound be able to differentiate the differential diagnosis? Can you differentiate a transient synovitis from a blood or a septic arthritis? Or do you think we should go ahead with a CT or MRI? How would you decide what is the best imaging modality for such a patient? Dr. Kannan?
Sir, not best. The first investigation should be the ultrasound, sir. So we need to first confirm there is a effusion. So it's a fluid is there or not. So the ultrasound is the best modality. If the fluid with internal echoes are there, then it's towards the septic arthritis. So before we call it, it's a transient synovitis. We need see the child, the CRPs, the ESR, how the any infection markers are increased or not. So if no increased markers, not significant increased markers, clear fluid, only synovial thickening, it's a transient synovitis. If internal echoes are there, it's a septic arthritis, if monoarticular. That is the first modality of choice, sir.
Ultrasound.
Dr. Ashwath, can I
I narrow down the list of investigation on this child because initial consultation, they concentrated on the calf muscle and they did the ultrasound of the muscle, not the knee joint. And the X-ray they took for the ankle joint in the referral hospital. So this is narrowed down. I thought I will go for MRI first and then, if necessary, CT to rule out that. That is the list of investigation I have proceeded with this child.
Okay, Dr. Ashwath, can I answer your question on
quick comment, sir?
What is in limb? So, from an orthopedic point of view, in the normal gait cycle, 60% of the time your leg stands on the ground. We call that as a stance phase. And 40% of the time your leg is off the ground. So it's a 60-40. When this changes, when the stance phase get reduced and the swing phase increases, we call that as an antalgic gait and we call that as a limp. So whenever the stance phase is reduced, which is 60% of the normal gait cycle, so we call that as a limp. So the child tries to avoid putting the leg onto the ground. So that's it.
Thank you. Thank you. Dr. Jalil, you can proceed with the case presentation.
Dr. Ashwath, in earlier case pointed out, the limp in the child, age-wise, I can have one is the limp, painful limp and a painless limp. This is very important. And it is categorized by 1 to 3 years, 4 to 11 and beyond 11 years. So that's what I proceed to this baby.
Your child, what does the investigation show, sir?
Sorry?
In your child, in the case that you are presenting, this child CT scan you said you did. Can you go ahead with the images, sir? No, what is the investigation reveal? No, what is it? You said you have done a CT scan because the child did not cooperate for an MRI. Can you please tell us what?
Only for MRI of the left knee. We couldn't do that MRI, but with that we proceed for the CT of the knee joint. Earlier investigation, they didn't concentrate on the knee.
Okay. So your final diagnosis is a traumatic transient synovitis. Yes.
And this as age-wise 1 to 3 years, the commonest thing with this constitutional symptom, as in the previous case we discussed about the septic arthritis and osteomyelitis and the traumatic transient synovitis, and also narrow down some metastatic swelling. All this has to be considered.
How did this?
And this child, seen by an orthopedic surgeon, we just admitted the child for rest and immobilization with the sling, and we gave antibiotic coverage. Of course, we stopped the antibiotic after giving the fracture negative. My question to orthopedic surgeon, this is a baby with an effusion. How often you go for a needle aspiration of the synovial fluid, sir? Will it help?
Dr. Lenin, to you. When will you aspirate a knee joint swelling?
Yeah, if the knee swells up immediately after a fall or an injury, it's likely to be either a fracture inside the knee joint, or it could be injury to either the meniscus or the cruciate ligaments. If the knee swells up within a half an hour to 1 hour following a history of fall, it's likely to be traumatic, and there's collection of blood inside, either due to fracture of one of the structures inside the knee joint, intra-articular fractures, or it could be due to injury to the meniscus or meniscal tear or a cruciate ligament tear. If the swelling starts after 12 or 24 hours, if the parents say the child fell down yesterday and this morning they've noticed pain and swelling, then it's likely to be due to sinusitis or simple effusion of the knee joint due to some inflammatory process going on. And to be honest, like a child with septic arthritis will never put the leg down on the floor. The child will not weight bear at all. Even 0 to 5 to 10 degree range of movement is absolutely impossible in cases of septic arthritis. The child will be very febrile and the child will be very irritable. They just won't allow even a single drop of pus inside the knee joint. The range of movement is the one thing that we look for when the child comes present to the emergency. And if there is a reasonable range of movement, we are quite comfortable saying that this is unlikely to be septic arthritis. And the video shows that the child is walking and running around with the knee swelling. So I could say just by the looks of it, at that instant, I will rule out a case of septic arthritis. This is not septic arthritis. This is likely to be simple synovitis or effusion inside the knee joint. I will have a very low threshold for aspirating the knee joint. When the inflammatory markers have gone up, when the child is not moving, when the ultrasound shows internal echoes, hyperechoic shadows inside the fluid collection, and if there is suspicion of a septic arthritis, I will stick a needle under local anesthesia and try to aspirate. But most of the time, it's either likely to be due to simple hemarthrosis or effusion, child walking around, simple anti-inflammatory and a bit of support and ice packs and other things, limb elevation will be able to solve this problem.
Dr. Suma, a quick word from you. Young male child trauma, would hemophilia
Absolutely. I think coagulation profile is a very important test in this case. And we have to consider the possibility of this being the first presentation of a potential coagulation of this thing. A male child, young child, and following an injury that was recorded as apparently trivial. And quite a remarkable finding, like a large effusion in the child. So I think it cannot be missed out. Definitely a traumatic injury is first on the cards here, as everything Dr. Lenin was saying is absolutely right. And this is not at all the picture of septic arthritis.
Okay, thank you.
Unless partially modified by treatment.
Dr. Ashwar, during when the radiologist was telling ultrasound during the septic arthritis acute phase, will the child allow you to keep the probe on the...
They do it. Yes. Ultrasound is okay. As in ultrasound by expert radiologist is easily possible.
Okay.
MRI, you often I have a very low threshold for doing a GA MRI when it's necessary.
Any invasive study, especially dealing with joints, is not at all highly warranted. We have to be double cautious about it. Number one. Number two, to the orthopedic surgeon, how confident that already this baby had 10 days of illness and all, the suppose it's progressive, how confident as a general pediatrician we have ruled out septic arthritis or osteomyelitis? What is the red flag for that?
Osteomyelitis, again, we have to keep observing the child from time to time, see whether they are responding to simple NSAIDs. And if there is any doubt, if the patient's condition is going down, raised inflammatory markers and the X-ray, by 2 weeks, he should be able to see some simple periosteal reaction if it is a case of osteomyelitis. And if necessary, and if there is any doubt, we will have a very low threshold for getting an MRI scan. MRI scan under simple sedation or general anesthesia will easily pick whether it is a case of osteomyelitis or whether before the X-ray findings comes out. So MRI will be the ultimate investigation of child if the child is not improving by 10 days or 2 weeks after inflammation, anti-inflammatories.
Thank you, Dr. Jalil, for the case presentation. Can we go on to the next slide? We are running behind schedule. We have taken 50 minutes for 2 cases.
Only one question, Ashwat, to Dr. Lenin Babu. We know commonly transient synovitis is common in only the hip joint. Is it common in knee joint too? Whether you have come across?
I agree with you, sir. It's not that common in knee joint. Okay, so when compared to the hip joint, transient synovitis of the knee joint is not that usual. It's not that common.
Thank you. Thanks for that input. Thanks, Dr. Jalil, for being a presenter and so enthusiastic in sharing your experience. Thank you. Dr. Tirun, Dr. Nilufar, if she is ready, can we have the next presentation?
Yes, sir.
Dr. Nilufar?
Yes, sir. I'm here, sir.
Yeah. Turubas, can you start a presentation, or Dr. Nilufar can do it from KKCTH?
Sorry, she can do it herself.
Perfect. Right. You can start, doctor.
Okay. Good evening, everyone. I'm Dr. Nilofar, pediatric resident of Kanchi Kamakoti Children's Hospital. I'm here to present a case scenario under the guidance of Dr. Janani, Senior Consultant, Department of Pediatrics, Kanchi Kamakoti Children's Hospital. I thank everyone for giving me this wonderful opportunity. So, moving on to the presentation, here's a 2-year-old child who's first born to a non-consanguineous married couple, who's a previously well child without any significant past history, who's a developmentally normal child, who came to our hospital with the complaints of fever for 2 months duration and leg pain for 1 month duration. So elaborating the history, fever for 2 months duration, which was low grade, he had each spike in a day and he was active in the interfebrile period, and the fever was intermittent, which was relieved with paracetamol and was not associated with chills or rigor. And he had leg pain for 1 month duration, which was involving both the legs below the knees, which was intermittently relieved on medication, but the child used to cry at night of pain and was not able to sleep because of the pain. So gradually the child stopped walking and he could not bear weight with his legs and he preferred to be carried or lying down. There was no history of swelling of any joint. There was no history of loss of weight or appetite. There was no history of trauma, no history of rash or recurrent oral ulcers. There was no history of early morning stiffness, no history of loose stools or abdominal pain or hematuria. There was no history of bleeds. So on examination, the child was observed to have pallor. There's no other general examination findings like icterus, clubbing, any rash or significant lymph node involvement. Coming to the systemic examination, CNS examination, including the tone, power, reflexes were normal, and CNS and respiratory system examination were normal. Per abdomen, it was soft. There was no abdominal distension. There was no organomegaly or any palpable mass noted. Coming to the musculoskeletal system examination, on inspection, there was no obvious joint swelling. On palpation, there was no warmth noted, but the pain was very severe that the child would not allow us to palpate. And he always prefers to keep the legs flexed. When we try to extend the knee, the child would cry of pain. So with the above complaints, the child was admitted outside and he was treated as a case of COVID arthralgia as the COVID antibodies IgG came out to be positive. So he was given a trial of oral steroids for 3-week duration. Intermittently, the child had relief in symptoms, but then he had persistent symptoms. So he was taken to the other hospital where he was treated as a probable case of juvenile idiopathic arthritis, and they gave him steroids and oral methotrexate. But the pain did not subside.
Take a break here, Dr. Nilufar, and take Dr. Sangeeta's inputs. Dr. Sangeeta?
Yes, yes, sir.
Yeah, this child has come with fever without any joint pain and swelling, whereas everywhere the treating physician has chosen arthralgia or juvenile idiopathic arthritis when there has been no joint involvement. Could you elaborate on what are the muscular disorders? Do inflammatory myositis present like this? What would be the differential? Because the complaint is generalized. Would you please guide us on what are the neuromuscular conditions that one would need to consider?
Yeah, and this child has presented with a fever of 2 months duration and a leg pain of 1 month duration, predominantly affecting both the lower limbs. And it was present throughout the night, and the pain was impairing the child's activities of daily living. So, and she also has mentioned there was no joint pain, joint swelling, or skin rash. So, the differentials which we can consider in this child could be inflammatory myopathies or inflammatory myositis. So which includes dermatomyositis, polymyositis, or overlap syndromes, or it could be metabolic myopathies, which has been precipitated by an intercurrent illness, but there is no history of any myoglobinuria. Am I right, Nilofer? There is
Yes,
no passage of any
No,
dark
ma'am.
colored urine.
No, ma'am.
So metabolic myopathy also needs to be considered. And other possibilities of muscular dystrophies or congenital myopathies cannot be considered as child, because premorbidly he was developmentally normal, and there was no worsening or progression of weakness. You have in the neurological examination, did you identify any pattern of weakness, any proximal weakness?
No, ma'am. No, ma'am. There was no weakness, ma'am.
Sure. So in this particular child, inflammatory myopathy is one high possibility, followed by metabolic myopathy.
In the absence of any skin rash, would dermatomyositis still be on the cards, ma'am? Do you need to have dermatological manifestation?
Yeah, dermatomyositis, of course, you have the Peter and Bogan criteria for diagnosis. So you need to have the typical heliotrope rash, and you need to have the typical pattern of weakness. Here, there is only pain is only the predominant symptom, and there is no weakness 1 month into the illness. So, polymyositis, again, there is pain, but there is no weakness. So 1 month into the illness, by this time, the child should have developed some form of proximal muscle weakness, which has still not happened. But if you need to consider a neurological cause, inflammatory myopathy could be considered, and metabolic myopathy could be considered, where the pain would be one of the predominant manifestation.
And she had mentioned a condition called COVID arthritis. Could you please very briefly tell us what are the neurological or neuromuscular implications of a past history of COVID, ma'am?
So the COVID-related neurological manifestations, our adult counterparts, they see more neurological complications in patients with COVID rather than in pediatrics. But of course, we do see in consults, like we see element facial weakness, isolated Bell's palsy, and we have seen GBS after a COVID infection. And also we have seen COVID, post-COVID, we have seen ADEM, acute disseminated encephalomyelitis. And we had a child who had presented with acute necrotizing encephalopathy of childhood, who had presented with acute encephalopathy with rapid coma within 24 to 48 hours of the onset of illness. So the MRI pattern was typically suggestive of trilaminar pattern, suggesting the diagnosis of acute necrotizing encephalopathy. And that child we treated with IVIG and steroid, and she clinically improved. And other MISC-related thrombotic events we don't see very often, but we have seen in a few of the cases. So these are the neurological manifestations which we have observed in the last 3 years. But our adult neurologists, they encounter more neurological complication in adult patients as compared to the pediatric population.
Thank you. Dr. Nilofer, can you proceed?
Okay. So coming to the investigations.
Can I just pipe in? Ashwat,
Yes.
can I pipe in?
Yeah, please.
All the symptoms that she has presented are clearly suggestive of a malignancy. Just go back to your presentation slide, earlier presentation slide, Nilofer. So this child is having daily fever with night pain and has progressively stopped using both legs, has basically functionally deteriorated. Okay. Now, regarding swelling, warmth, redness. Now, the peripheral joints, yes, if there is an arthritis, you will see swelling or warmth, redness, etc. The axial joints, the hip joints, the shoulder joints, you do not see if there is swelling. They are very deep. You cannot notice swelling outside. It is restriction that you have to look for. I am very sure you could not have even examined this child's hip joint for restriction. The child would have had a lot of pain, wouldn't have let you examine at all for restriction. The second thing is that the progressive loss of function. The child has stopped walking completely. That's a very, very serious thing. And even the findings that she's put down, the first diagnosis in this child is malignancy. completely malignancy. The tenderness, it's what happens. 40% of ALL presents with musculoskeletal symptoms.
Point taken.
Okay, and this is the exact history they present with. This tenderness on palpation, this difficulty to bear weight, this is all very, very typical. And when the child has been given steroids, it can definitely affect all your investigations that you're going to do. Most children with ALL do not have organomegaly, they do not have lymphadenopathy, they do not have palpable mass, they will have periarthritis rather than arthritis per se. But the story here is full of red flags.
Towards malignancy. Point taken.
Full of red flags.
Okay, thank you. Dr. Nilofer, let's see how the case unfolds.
Okay, sir. So, investigating, we found out that the series of counts showing low hemoglobin levels, and the counts are normal, and platelets showing a decreasing trend, and ESR or CAP were elevated. So, ANA down outside was negative, and peripheral smear did showed a Role formation, rate of neutrophilia with mild thrombocytopenia. There were no atypical cells, and UST hip and abdomen done outside was normal. So, with this background, for any childhood limb pain, I would offer the following differential diagnosis. First is infection, but here infection can be ruled out as infection would have a shorter course of duration, and it will have some signs of infection like joint swelling or tenderness, and warmth will be there. And next, I would like to, next there was no history of trauma and inflammation. Inflammation, juvenile idiopathic arthritis, which can be ruled out as it is not localized to a particular joint. Then dermatomyositis, as ma'am mentioned, but that can be ruled out as a child did not have any rash. Henot's condyline purpura, because a child did not have any abdominal symptoms or hematuria. And SLE, no rash was there. Next is hematological manifestations like sickle cell disease and hemoglobinopathies. There's no history suggestive of any hematological conditions. Next is malignancy. The most favorable will be malignancy, leukemia, neuroblastoma. And next is non-inflammatory conditions like growing pains and fibromyalgia, neuropathy, which is not consistent with the history and the examination findings. So we went ahead and did ultrasound abdomen, which showed a midline mass in the upper abdomen, which was encasing the celiac axis with multiple calcified foci within the mass. And there were multiple enlarged retroperitoneal nodes, which are present in the mid and the lower abdomen. All these findings were suggestive of small blue round cell tumor. So as a part of malignancy workup, we did bone marrow examination. The aspirate showed atypical cells, and we went again with the flow cytometry, which showed CD56 and CD81 positive, which were consistent with neuroblastoma.
Okay, can you take a block? Can we take a break there? Dr. Kannan? Dr. Kannan?
Yes, sir.
Would you say this, would you agree with this ultrasound abdomen interpretation? Is it specific for small blue round cell tumor, or is it possible that the child has a Wilms tumor or a nephroblastoma or their non-Hodgkin's lymphoma? Are there other differential diagnosis, or are these findings consistent with only one diagnosis of neuroblastoma?
How I interpret, sir, here they not mention about the kidney. So the midline mass is separately seen from the kidney. So a large separate mass in the retroperitoneal region with the calcific foci, it's actually neuroblastoma metastasis. It's actually, if the tumor is in that kidney, it's replaced the kidney, then only it will be the confusion come. It's a Wilms or neuroblastoma thing. But it's a, if it's a calcification is there, it's most probably neuroblastoma. In the child, calcified retroperitoneal lesions are mostly neuroblastoma, sir.
Sure. Thank you. Thank you. Please proceed, Dr. Nilofer.
This is the bone marrow aspirate showing a small round blue cells. And this is immunohistochemistry staining showing CD56 positive and synaptophysin positive, consistent with neuroblastoma. So, as a part of staging workup, we did PET-CT, which showed retroperitoneal mass and multiple lymph node and bone marrow mets. So the child was started on, so diagnosis of neuroblastoma stage 4 with bone and bone marrow mets was involved. And the child was started on rapid Kojak induction chemotherapy. The child received chemotherapy. He attained remission. He also underwent autologous hematopoietic peripheral blood cell stem cell transplant. He completed radiation. But he recently got admitted with the complaints of fever and bone pains. Now, in view of persistent symptoms, we did bone marrow workup, which showed, which was suggestive of relapse in the bone marrow. So, child is to be started on a trial of salvage chemotherapy. So
Thank you so much, Dr. Nilufar. Dr. Janani, Senior Consultant, was in charge of managing this child. Can you wrap up this session with some take-home messages for us, ma'am? Janani?
Yeah. So I think, can you hear me?
Yes, madam. Madam, mask eduthuko.
Mask eduthuko. Yeah. So any child with limb pains, I think before giving steroids, we'll have to evaluate them and completely, and then decide on steroids and other things. Immunosuppressants should not be given without a bone marrow and complete evaluation. That will be my take-home point.
Thank you, ma'am. Thanks for that wonderful case presentation.
Ashwath, ஒரே ஒரு question Nilofarku. Whether the nocturnal pain was relieved by the massage or whether it was exacerbated by the massage. The only one question I want to ask for the postgraduate. In this patient, whether the nocturnal pains were relieved by the patient's massage or it was aggravated by the massage.
Actually, there was no relief, sir.
No, usually if it is aggravated, actually it indicates mostly that is very good clue for a malignancy.
Correct. Because of the periosteal inflammation and the infiltration.
So, Ashwath sir, one other thing, like in this child, other neurological cause which we can suspect is like whether it's a paraneoplastic immune-mediated polyradicular neuropathy. So yes, the pain might be because of the bone metastasis. They can have nerve root compression, they can have a radicular pain, but they will have a typical pattern, sharp lancinating pain radiating to the anterior or posterior aspect of thighs depending upon the root involvement. And also they will have associated motor pattern of weakness and also sensory loss and loss of ankle and knee jerks depending upon
Would fever be an important part of these inflammatory polyradiculopathies, ma'am? Here there is a concurrent history of fever as well.
Yes, sir.
And there was persistent elevated CRP and ESR, which is probably what misled the physicians into thinking that it was an inflammatory rather than an infiltrative condition.
Sure.
Thanks, Dr. Nilufar.
Thank you, sir.
Can we go on to the next presentation?
Yes, sir. Shall I share the screen, sir?
Yes, Dr. Karthik. Dr. Jali, your audio is not clear. Can you put your comments in the chat box? Dr. Jali, you're not very clear in your audio. Can you please type your comments in the chat box?
Okay, fine. Thank you.
Thanks, sir. Dr. Karthik, can you go ahead with your presentation? Start screen sharing, please.
Okay, sir.
Dr. Karthik?
Yes, sir.
Do you have difficulty, ma'am?
Yes, sir. Not able to open, sir.
Can we have Dr. Jayashree or Dr. Arun, please? In case you have some technical difficulty, is Dr. Jayashree ready to?
Yeah, I'm here. I'm ready, but Dr. Thiru has to share the slides.
Dr. Thiru?
Dr. Thiru share. Good evening, everyone. Thank you, IAP TNSC, for giving me this opportunity to present this case. We had a 9-year-old girl who presented just prior to the first wave of COVID with history of pain and swelling of ankles of 2 weeks duration. There was limp of 2 weeks duration. And the mode of presentation was the right ankle was first affected according to the parents, which got swollen and painful, followed by left in 3 to 4 days' time. Elaborating on the presenting complaints, this child did not have any fever, There was no history of trauma, no history of skin rash. There was no early morning stiffness of joints, and no night sweats or night pain. No history of oral ulcers or eye redness or any other history suggestive of joint involvement. No history of skin patches, hair loss, loss of weight, or loss of appetite. There was no history of recent diarrhea or dysentery. There was no significant past history in this child of similar episodes. No family history suggestive of any autoimmune disease. Next slide, please. So to elaborate on this pain and swelling, they were gradual in onset and slowly progressive. First, they noticed the pain came, followed by the swelling, and there was difficulty in weight bearing. So she limped first on the right leg, then followed by left. The pain was dull, aching one, and around the lowermost part of the leg, around the ankle. It got aggravated more on weight bearing and walking for a longer period, but however, she was able to walk with pain. And the pain got relieved by rest. There was a history of sore throat, which presented a month back, which was diagnosed as acute tonsillopharyngitis, and she had received appropriate antibiotics. With this history, she met a general physician who gave her paracetamol for a week without relief. She did not find much change. And then they met an orthopedician who had taken an X-ray, which I did not have, but the report was unremarkable according to the father. And she was given antibiotic cefuroxime for a week. And there was no relief with these two medications. There was no history of contact with tuberculosis as well. So summing up the history, we have a 9-year-old girl with pain and swelling of both ankles, one followed by the other, and a duration of 2 weeks. Gradual in onset and progressive in nature. The pain was moderate, incapacitated her from walking or weight bearing for a long period. But however, she was able to carry on with her routine activities at home. Coming to examination,
Dr.
she was
Jason,
conscious.
can you please stop it? Dr. Suma Balan, from this history, what's your differential diagnosis you can think of, Dr. Suma Balan? Dr. Suma Balan. Hello, Dr.
There's a
Suma?
lot of, yes, sorry, I unmuted, yeah. So I can see that there is lots of symptoms, very little signs, very little objective features to see for lots of symptoms. It would have been good to see photographs, because when we say swelling of ankles, are we actually saying there is synovitis? Is there restriction of the ankle? She has definitely mentioned that there is no early morning stiffness at all. Diffuse tenderness over lowermost part of legs and anterior lateral aspect of ankle is slightly difficult to interpret unless we have imaging to go with it. So here, what is there in the right ankle, I do not know. There seem to be some findings in the left ankle, which is not localized to the joint alone. Whether that will explain all the symptoms that she has, I would want to investigate what is happening in the left ankle, look for her bloods and inflammatory markers, basic imaging. If necessary, if everything is completely unpredictable, if necessary, we may need to do an MRI as well. In the back of my mind will be chronic pain syndrome for children like this, because I see lots of children who come with lots of symptoms, very little objective findings, and very little in the form of tests, the basic tests that we do, which show that there is a pathological process going on. So that would be in the back of my mind. But before I confirm that, I would want to do the basic evaluation.
Can I proceed with the examination?
Doctor, please. Yeah, Dr. Palniraman, please.
Madam, is it possible with the swelling? That is chronic pain syndrome with swelling.
See, the swelling can be very subjective. Many times people say there is swelling, but I don't know what is the swelling. Is it a very mild fullness? Is there actually a big effusion there? Is there a synovitis? So I said, unless there is imaging to tell me what is exactly there, or a photograph for me to see, hearing swelling alone doesn't tell me anything in this scenario. there is nothing in the history to go for a significant inflammatory process actually.
Okay, madam. Please, Dr. Jayasri, please proceed. Yeah.
Yeah, so we proceeded with the examination. We had a conscious child, well oriented. She walked into the consultation room with support of her parent, and she was limping the right leg. Antalgic gait was noted. Weight was 23.7 kilos, which is 25th centile for this child, and height 138 centimeters, which was normal, 50th centile. Vitals were normal. The child's systemic examination, she was afebrile, ear, nose, throat normal, no goiter, no generalized lymphadenopathy, pallor or icterus. Skin and eyes were normal. Proceeding with examination of systems, cardiovascular system, respiratory and abdomen were normal. To get a quick survey of musculoskeletal system, I did a P-GAL. The gait was antalgic, arms normal, the spine was normal, and on local examination of both the legs, hips and knee range of movements were normal. There was no swelling or pain. Coming to the ankles, the swelling was mild on both ankles, ma'am, and it was noted on the anterolateral aspect of the left knee, left ankle, and there was a diffuse swelling over the lowermost part of the leg close to the ankle joint. There was no warmth or redness. No, ma'am.
Could that be a thrombophlebitis? Okay.
To be symmetrical, affecting both joints at the same time. I did not think of that at that point of time. There was no warmth or redness over the skin as well. No joint line tenderness bilaterally on moving the finger towards the medial and lateral malleoli. Movement of both ankles, dorsiflexion and plantar flexion were possible but painful. Other joints normal.
Yeah, Dr. Jayasri, please wait. I think Dr. Lenin Babu, I think the child is working with limping. Okay, that another thing is only diffuse tenderness only noted. So what's your thought of your differential diagnosis? How will you proceed further?
So involvement of more than one joint, symmetrical. So it rules out any history of trauma and other things. So fracture is unlikely. We are dealing with a systemic problem if it is more than one joint. Either it could be either an inflammatory or an infective process. Most likely, I think it is a synovitis of the ankle joint, which has led to some mild effusion inside the ankle. So that will be my diagnosis, sir. So
Dr. Lenin, if it is going to be a unilateral, can Brody's abscess can present like this?
Brody's is actually a small contained infection inside the metaphyseal area of the bone. So it's highly unlikely to present as an ankle swelling. So the ankle movements are painful, but it's likely to be some fluid inside the joint. Either it could be a simple transient synovitis type of thing with synovial inflammation and fluid, or we have to rule out any infective process based on whatever the investigations, either in the form of an ultrasound or an MRI.
Dr. Lenin, how common that ankle joint synovitis? Usually you're going for knee and it's common as well as hip joint. And ankle is uncommon, no? That synovitis.
Very unusual, sir. We don't see that many cases of ankle synovitis, but considering the history, what we have seen so far, with the spontaneous onset of pain and swelling of only the ankle, the rest of all the examinations are normal. Still, we do get isolated cases of it. And even in the previous case, what they were talking about, we do see multifocal osteomyelitis. Recently, Dr. Ashwath and myself were dealing with a case of multifocal osteomyelitis involving femur, tibia, mandible, and the humerus as well. We drained all the collection. So we get some unusual presentation from time to time. So this could be likely to be a case of ankle synovitis. We don't know. It could be infection has to be ruled out. Okay. And
Dr. Jayasri, please proceed.
I would say that for infection, there would be, especially infection within the joint, you would have some nocturnal pain history. You would have more history here and more findings here, which is from what has been presented so far. I'm not convinced that objectively there is an inflammatory arthritis going on in either ankle. So unless I see the imaging and thing, it'll difficult to actually say what is going on here.
Dr. Jayasri, please proceed.
Yes, ma'am. So we proceeded with basic investigations. The counts were normal, platelet count, WBC counts. The hemoglobin was 12 grams per cent. Peripheral smear was normal. There were no blast cells or abnormal cells. ESR was elevated and CRP was, however, normal. Considering the past history of acute tonsilopharyngitis, which has happened 1 month back, and the age group, I still went ahead and did a ASO titer, which was normal. And ANA by immunofluorescent method was normal. Rheumatoid factor was negative. With this investigation, still we couldn't conclude much, but the probable differential diagnosis which ran in my mind were whether it could still be an osteomyelitis, which is either tuberculous or it could be reactive arthritis in this age with any trivial trauma which the parents were not aware of, or whether it is arthritis which we are dealing with, again, not sure from the examination as well as the initial investigations. Rheumatic arthritis is very unlikely with the investigation and the findings. Juvenile idiopathic arthritis is something in my mind. And of course, in the girl child of this age, autoimmune disorders like SLE was also in the cards. Ligament injury we thought of, but then symmetrical presentation in both legs, very unlikely. And the secondaries from malignancy, hematoreticular malignancies was also in my mind as a differential diagnosis. So with this investigations not yielding much, I proceeded with an MRI.
Yeah, please 1 minute, Dr. Jayashree. Dr. Kannan. Dr. Kannan.
Yes, sir.
Yeah, this scenario, so what kind of investigation you like to do it? Suppose the resource limited setting, now there you want to go for MRI or you want to go for, first you can go for X-ray or CT, and what you like to do it?
No, sir. In this scenario, their differential will be the like a systemic disease. But sorry. So first we need this case, we need MRI, sir. Because of that, they suspect systemic disease.
Okay, can you read this MRI, Makana? Can you?
Yes, sir. This actually they mentioned coronal IR inversion as a recovery sequence. There is a edematous changes in the epiphysis and that adjacent plate, growth plate region and the adjacent epiphysis region. So there is some edema in that plate and adjacent to that epiphysis region. Actually,
metaphyseal, is that metaphyseal or epiphyseal? Or
here they mean
to be spared on both the sides. Okay,
it's adjacent to the growth plates at both sides.
Yeah. It's more involved metaphysis than the
Here,
epiphysis.
this is a metaphysis, this is the plate and this is the epiphysis. But interestingly, it's both sides involved. So in this scenario, actually, as a radiologist, I want to screen other joints. So I want to see. So that is important. So this actually, this is an interesting case. So here they suspect some pathology in that ankle. That IR-MR shows there is a bilateral symmetrical signal change. So actually, we need to proceed with whole body MR-IR sequence. That's what the ideal one.
And can that PET useful for this condition if you want to go for a scan?
No, sir. This
no whole body MRI.
Okay, right.
So even that first the patient come with only the single part MRI, the radiologist need to speak with a pediatrician, and this study should convert as a whole body MR. Because the child already in the sedation in the gantry, we need to immediately do this.
Yeah, please.
Before we go to the next slide, can I just say, are we sure this child did not have nocturnal pain? Nocturnal pain would be a very, very classic symptom in these findings. Actually, are we sure this child does not report nocturnal pain?
Yes, ma'am. She was very, very sure. The parents were also sure that she had a good sleep. They did not give any painkiller.
Were they giving painkillers?
No, they were giving only paracetamol.
Yeah, but that could be the reason why she's not having nocturnal pain. So that is a very important history, because the thing is, whatever you were presenting, there was very little in the joint. So unless you see the patient in front of you or some pictures, it's very difficult to know how to take that history. Here, the story here is really, when you see this MRI, this is CRMO, very likely. The story here is nocturnal pain, which would be quite difficult for the child at that time. And that is possibly why they're giving paracetamol every night for the child to sleep.
Yeah,
That's a very important part of the history.
Okay, ma'am. So next slide, please.
Yeah, next.
So this was the MRA report given by the radiologist. And they also screened both knee joints, which were normal. And their opinion was whether it was Brody's abscess. They were also not sure about what was happening in the joints based on the MRI. And this is the situation we landed up when we did the MRI of both ankle joints. So moving further, reasonably having ruled. Yes, ma'am. So I started this child on naproxen because still pain and swelling were there, and she was not getting relief from paracetamol. Next slide, please. So this child was started on naproxen, and within 48 to 72 hours, she showed good improvement. So again, here the provisional diagnosis were whether it could be juvenile idiopathic arthritis, but again, MRI did not show any findings to suggest arthritis as such. So at this point of time, I had the differential of chronic recurrent multifocal osteomyelitis. The fact that she responded very well to naproxen gave this clue. But after 2 to 3 weeks, I stopped the medicine. Within a month, she came back with same symptoms.
Yes.
And she was restarted on naproxen again for 2 weeks. And this point of time, we consulted the pediatric rheumatologist. This event happened during the first COVID wave, where transport of the child, everything was a problem. Even investigating was a problem. So Dr. Satish at CMC Vellore was a great help over the phone. And he advises to go ahead with a whole body MRI, as Dr. Kannan and Dr. Suma Balan rightly said. So the whole body MRI revealed the following findings. Can we move to the next slide, please? So these were the whole body MRI findings. So the multiple joints were involved. By this time, we did a whole body MRI. It was almost 4 to 5 months after the initial presentation. So by this time, there were findings in other bones as well, not only tibia, fibula, ilium, calcaneum, callus, many bones were involved. So with this, we concluded the diagnosis of CRMO. She was restarted on naproxen. We continued it for a longer period this time, and we reviewed her.
What is CRMO, madam?
Chronic recurrent multifocal osteomyelitis. Now it is renamed as CNO, chronic non-infectious osteomyelitis.
So this is quite common. It's not uncommon. I have about 60 patients with this condition. We published when we had around 20, I think. The question is, they present with pain. It's classically bone pain. You have to tease out the history. It's not arthritis here. It's bone pain that is the classic history here. And they have usually school-going age children. If you have below 5 years of age, think of syndromic autoinflammatory CRMOs. It's metaphyseal involvement. Sometimes diaphyseal can also be seen. Multiple places are there. It can involve the spine. Every patient needs whole body MRI to look for asymptomatic lesions in the spine and large lesions elsewhere which may not yet be symptomatic. Asymptomatic lesions in the spine can subsequently cause weakness of the spine and collapse. So those patients will always be treated with pamidronate upfront, as compared to the others where you can try an NSAID first and then work down. It's an inflammatory disease. It's an auto-inflammatory disease. It's not due to infection. Antibiotics and interventions are unnecessary. If you have only one lesion, a biopsy is important. If you have a number of lesions, you don't need to do a biopsy, especially if the findings are typical.
Yeah, thank you, Madam. It's a nice case presentation by Dr. Jayasree. And next, we'll move on to next case presentation.
Thank you, sir. I just wanted to add one thing. We proceeded with pamidronic acid for this child, ma'am, because she was again and again relapsing. And we gave 4 cycles at 3 months interval. And after that, now it's 1.5 years, and she is completely normal so far, no relapse so far. And she has gained weight and height normal for her age, and no swelling or pain in any joints so far, ma'am. Thank you.
Excellent. Have you re-imaged? You need to do a whole.
I haven't.
You need to do a whole body MRI, re-image, and make sure that you've got good recovery.
Yeah, Dr. Palliraman, please.
And Dr. Suma, unlike
Yes.
these conditions, little uncommon conditions, we commonly come across particularly the reactive arthritis. Can you particularly throw some light on reactive arthritis, which is very common in the day-to-day setup? Can you throw whether large joints or small joints and common reactive arthritis versus post-streptococcal reactive arthritis? Can you throw some light,
Yes.
which is very common in day-to-day practice?
Okay, so the first important thing about reactive arthritis is there has to be objective arthritis. It's not about patients saying, I have pain in my elbow or pain in my knee. It is about there being objective arthritis. You have to see the swollen, restricted joint, etc. Now, there are a number of reactive arthritis syndromes. So, acute rheumatic fever is also a reactive arthritis in the broad phase. Rheumatic fever is a very, very symptomatic condition. It's very alarming. The patients will be so sick, they will be needing admission. The post-streptococcal reactive arthritis are not so acutely sick patients. They present usually within 7 to 10 days after a streptococcal infection. And they could have large joint involvement, could be monoarticular, it could be polyarticular, it could be a mixture of small and large, it could be enthesial, it can have associated myositis also. But it will be what we call a relatively acute presentation. And they could have some evidence of inflammation on your blood test. There will be a history of a streptococcal illness recently, and an ASO is useful in these circumstances to establish that they had a recent streptococcal infection. The common caveat that happens is a child who comes with some little bit of joint pain and gives a history of a cough 1 month back, and when ASO of 400 is all put together and caused reactive arthritis when there was no arthritis at all in the first place. And that is something we have, as doctors, we should not convert symptom into a diagnosis unless we see objective signs in between. So we have to train ourselves to look for the objective signs. It's very, very important. So joint pain, bone pain, arthritis, synovitis, restriction, all those things we have to look for and elicit those findings. And for reactive arthritis, all you need to do is give NSAIDs. You don't need to give anything more than NSAIDs. Give a good dose of naproxen for a week. Some of these patients may require another week or so, which is fine, but very, very, very rare to need steroids in these patients. For that matter, even
Last question, madam, whether post-viral reactive arthritis versus post-bacterial reactive arthritis, can you throw some light?
Again, that will come immediately after a viral illness. You'll have the history of the viral illness. And again, objective arthritis will be present and will respond very nicely to NSAIDs.
Whether large joints or small joints.
It can be either. It can be either. Usually, large joints tend to be involved more commonly, but small joints can also be involved. It can be symmetric or asymmetric. Asymmetric is more common.
Yeah, thank you, sir. Thank you. And next we'll move on to the next question. Yeah, Dr. Arun, please.
Yes, sir.
Yeah, please.
So, good evening, senior panelists and esteemed IAP members. I thank IAP for the opportunity. So I am presenting a 3-year-old male child who presented with swelling in the right inguinal area for 1 month, fever for 1 month, and limping gait for 2 weeks duration. And the right inguinal swelling was of 1 month duration, started as acute onset, painful, and preceded by few pus-forming skin lesions in right leg. That was couple of weeks prior to the onset of the inguinal swelling. And fever on 1 month, on and off, high grade with chills, intermittent. And the child was intermittently receiving treatment outside and subsided with treatment and was recurring back. The limping gait was for the past 2 weeks. It was associated with pain present throughout the day, more with activity and pain localizing to right hip and the inguinal area. No history of trauma or no other associated pain elsewhere in the body. And significant treatment history. The child had been receiving treatment for the same complaints in another hospital. So the child was diagnosed as right inguinal abscess there and treated with incision drainage and IV antibiotics, ceftriaxone and cloxacillin. Also, there is documentation of Cori vancomycin allergy. We don't know whether it was a Redmond reaction, but was documented in the discharge summary. And the child had a protracted course there. And the child had actually 2 to 3 times incision and drainage done for the inguinal abscess. And in spite of switching out to multiple antibiotics, and the child had a protracted course. And they had even done an ultrasound abdomen and CT abdomen there in the previous center, but it did not reveal anything except inguinal abscess. The patient had shown gradual improvement there and was discharged with oral antibiotics. Cultures there had no growth and no history of similar illnesses or abscesses in the past for the child. On presenting to our hospital, the build was okay. He was around 25th percentile for both weight and height. And the child was febrile, toxic, vitals were stable except for mild tachycardia, pulses were good. There were healed impetigo scars in the right leg, and incision and drainage scar was seen in the right inguinal area. Currently, the child had multiple inguinal nodes on the right side, around 2 to 3 centimeter size, tender, erythematous, warm, and no fluctuation could be observed. Systemic examination was normal, per abdomen was soft, no other neurodeficits. In musculoskeletal examination, the range of movement on the right hip was full, except for painful restriction of extension of right hip and settled with flexion. An antalgic type of gait was present on the right leg. So investigations, the counts, total counts were.
Arun, can you just take a pause, a small break?
Yes, sir.
Dr.
Yes,
Sangeeta.
Yes, sir.
Almost all the case scenarios that have been presented so far have been involving either the bone or the joint or the bone marrow. As a neurologist, would you want us to remember some neurological conditions which can present with chronic pain and limb, ma'am? Are there a take-home list of conditions that we would think of for neurological conditions other than dermatomyositis, inflammatory myositis? Would you, as a neurologist, tell us when to consider neurological causes for pain?
Yeah.
Autonomic neuropathy, peripheral neuropathies, do they present pain at all?
Yeah, I can say like limping neurological causes which could be
Please.
painless or it may be painful. So limping can be related to tone abnormalities. So it could be related to an upper motor neuron lesion or a lower motor neuron lesion. So in an upper motor neuron lesion, usually the limping when the child has a pyramidal weakness, they can have motor weakness in the pyramidal pattern. They can have associated stiffness and also have, because of the spasticity, they can have limb length discrepancies, and then they can have limping. And on examination, you can identify the typical pattern of weakness with brisk reflexes and extensor plantar response. In a child with an element pattern of weakness, again, it depends upon the site of element axis involvement, neurological involvement, whether it's an anterior horn cell disease, or it is a radical nerve root, or it is a nerve, neuromuscular junction, or a muscle. So again, typically, if you see an element pattern of weakness, they usually, if it is an anterior horn cell, acquired anterior horn cell causes like poliomyelitis, you will have an asymmetrical pattern, and you can have reduced tone, and also you will have areflexia, and the plantar responses will be normal. So if it is like a nerve root involvement, particularly the previous stage which we discussed, so when there is a nerve root compression because of a bone pathology or any other pathology, so you can have, or it could be because of the inflammatory polyradicular neuropathy as well, like GBS or CIDP. So you can have a radicular pain and also an associated other pattern of weakness along the nerve root involved. You can have weakness as well as the sensory loss. So if it is like a nerve involvement, like post-traumatic neuritis from following an intramuscular injections. So again, you will have a typical pattern of motor weakness depending upon the site of infiltration of the injections. And then you will also have the loss of reflexes. The motor weakness will be typically in a typical pattern, and also you will have the loss of reflexes. And if it is like a muscle related, the viral myositis is what commonly we see in the practice, which can cause limping. And other rare causes like metabolic myopathies or inflammatory myopathies also should not be forgotten in the list. And if you look at these are the common upper motor neuron and lower motor neuron causes for the limping. So other thing is movement disorders can also rarely cause limping, like dystonia. When you have a hemidystonia or like a dystonia which is affecting both the limbs, sometimes you can have dystonic postures which can cause limping. It could be unilateral or it could be bilateral. So movement disorders can also cause limping. So dystonia may be associated with dystonic spasms, which may be painful, or sometimes it might not be painful as well. So these are the causes for the neurological causes for limping, which we see in our office practice.
It was a very, very succinct and very brilliant, very, very short and sweet take home on the neuromuscular causes. Thanks, Dr. Sangeeta. Dr. Arun, can you proceed?
Yes, sir. So investigations, the child had a total count of 24,000 elevated. The child had hemoglobin was low, the other parameters suggesting iron deficiency anemia. CRP was high. Ultrasound showed right inguinal adenitis, few necrotic with evolving abscess. Ultrasound abdomen was done simultaneously and it was normal. So the provisional diagnosis was right inguinal adenitis persisting with evolving abscess. But because of the protracting history for a simple inguinal adenitis, a few other differentials were thought of. One was concomitant abscesses in other focus, probably psoas abscess, but ultrasound abdomen couldn't reveal anything. Resistant organism was thought because almost all the antibiotics the child had received was for mostly MSSA and no MRSA covering antibiotics had been given. Immunodeficiency was less likely because no history of any protracted illness or recurrent abscesses in the past. So, just a short approach. So in the painful limb, the first we are ruling out the trauma, and when there is no trauma, we are just settling for systemic symptoms are present or absent. So when systemic symptoms are negative, we can look for SCFE or Perthes or stress fracture or synovitis. In our case, systemic symptoms were positive. It was painful limb with systemic symptoms. So we can further classify as arthritis present or absent. When arthritis is present, we can mono or poly, we can go for differentials. In our case, arthritis was absent. So the possible diagnoses are hematologic malignancies, osteomyelitis, and psoas abscess. So the initial treatment, but since the ultrasound was negative and the child had already been done CT abdomen elsewhere in the previous hospital, we just started on antibiotics, no response, fever, limping, and pain persisted.
Doctor, before you proceed with the
Yes, sir.
treatment, like with whatever the systemic systems and the clinical findings that you have presented,
Yes, sir.
osteomyelitis is top on the list as far as the differential diagnosis is concerned in this case. So instead of CT, I would like to go for an MRI scan under sedation. The child is only 3 years old, which is a top on the differential diagnosis. An MRI will clearly show whether there is infective focus in the medullary canal, and the hypo range of movement may be normal. Okay, febrile patient was febrile, toxic with all the features. I would like to think it is a case of osteomyelitis, going for an MRI scan before proceeding with any treatment.
Okay,
so that
sir.
will be the way that I'll be dealing with this case. Okay. Huh?
Okay, sir. Thank you, sir. So we proceeded with CECT abdomen, which showed iliac and inguinal lymphadenopathy involving the iliac nodes also, with abscess extending to right iliopsoas muscle, and there was a right iliopsoas abscess with necrotic nodes. So this was the picture, sir, and the abscess was even abetting the urinary bladder, and both the inguinal and the iliac and the iliopsoas abscess was there and as a continuum. So then we proceeded with the surgical drainage under general anesthesia because of the abscess involving multiple areas with the help of a pediatric surgeon. Cultures were sent and antibiotics continued. After initial improvement, fever recurred despite antibiotics, but cultures still came sterile. The patient had to be referred to another tertiary center, unfortunately, in view of a parent's anxiety, because even after surgery, the fever recurred despite antibiotics. And the child was started on meropenem vancomycin there. Since it was documented as vancomycin allergy, we didn't know it was Redmond reaction or not. Out of fear, we didn't start vancomycin here. But since probably it was the reaction documented in the previous hospital, it could have been a vancomycin Redmond reaction rather than allergy. The child was started on vancomycin there, and the child had responded well after the surgery, and the child was discharged with oral linezolid. So the final diagnosis was right iliopsoas abscess with inguinal adenopathy and abscess. And the probable organism MRSA, but none of the cultures grew MRSA because the child had received multiple antibiotics at various points of time.
Thank you, Dr. Arun, for the brilliant presentation. Very quick question to Dr. Kannan. Because the psoas is so easily accessible from the retroperitoneum, would ultrasound, if you are suspecting iliopsoas abscess, will ultrasound be a good tool? Can we approach that anatomy from the posterior aspect? Dr. Kannan?
Yes, sir. Actually, we can do with the routine ultrasound itself, sir. But what usually happen, we will do like a pancreas, liver, spleen, kidney, bladder, prostate, they will cross. We will leave that. So if the clinician suspect psoas abscess, then only routinely as a radiologist, we will look for that psoas thing. Otherwise, we easily miss it. In this, that clinical content, the hip is flexed, that as a psoas abscess, usually the hip won't extend. So that is actually one of the clue to look for the psoas abscess. To look for the psoas abscess. If we don't see particularly, if then we easily miss the psoas abscess as a routine radiologist. So that need little extra conscious to look for the psoas abscess. Otherwise, if some first year PG or some young radiologists do, they won't screen the psoas. Routinely, they won't screen the psoas. So it will easily missed. So the clinical, if they mention as a psoas, they will look for. Otherwise, they won't look for in their routine practice. Another one, this case, sir, even though if the CT shows the psoas abscess, actually, I still want to go for the MR lumbar spine. Any lumbar spondylitis, anything is there. Because the 3 years child psoas abscess extending, it's look like unusual. Maybe Lenin sir know it, but usually what will happen that a spondylodiscitis, that collection will come along the psoas in the child especially.
I agree. The psoas major takes its origin from the lower thoracic spine. So whenever there is actually thoracolumbar junction is the most common site for tuberculosis part spine. So infection starting there will track along the psoas major and join the iliacus and presents as iliopsoas abscess around the lesser trochanter. So when you suspect or when you see a case of iliopsoas abscess, it's always worthwhile just screening the entire spine to rule out a case of tuberculosis.
Still, this case can be can have it. I'm not sure, but the psoas abscess, if it is, even though we need to rule out lumbar spondylodiscitis, any thoracic spondylodiscitis.
And Dr. Lenin, how do you, very briefly, how do we differentiate staphylococcus?
Dr. Arun.
Yes, sir.
Staphylococcus from tuberculosis. Is there a possibility, does MRA have sufficient sensitivity to distinguish between these two? Because in Dr. Arun's patient also cultures were repeatedly sterile, but the counts were showing a good leukocytosis with a polypredominance, making tuberculosis less likely.
I think most likely we have to go with the history and the rest of the clinical examination and the blood test to rule out between septic arthritis and tuberculous arthritis of the spine. Okay, so
routinely, would you recommend sending a CB NAT or an AFB stain on all pus material aspirated from an iliopsoas abscess? What is the proportion of stamp?
Absolutely. We will send it definitely when we collect an abscess, when we have collection taken out or drain and we have pus in our hand, we will certainly send it for AFB as well as gene expert to rule out tuberculosis. Okay, so we do. So especially the iliopsoas abscess, I would say around 30 to 40% are more likely to be more in favor of tuberculosis than septic arthritis.
We had, I would like to add on, sir, we had sent CBNAT also, which came negative, sir, because of the persisting symptoms. Yeah.
Okay. Thank you. Thanks, sir. We will move on to
the... You mentioned about the MRH.
Hello.
Sir, unga audio sariya illa. Jalil sir, unga audio sariya illa.
Can we have the next presentation, please? Dr. Karthik, we are running well behind time. Dr. Karthik from
Yes,
Erode.
sir.
Sorry,
Yes,
from Trichy. Sorry.
Shall I start, sir?
Yes, please.
Thank you, sir. Good evening, sir. I'm Dr. Karthikeyan, working as assistant professor in KAP Medical College, Trichy. I thank IAP TNSC office bearers and Dr. Ashwath, sir, for giving me the opportunity. It's a 10-year-old male child, fifth born of non-consanguineous marriage, presented with difficulty in walking, pain and swelling of both knee, ankle, and joints of hand, fever on and off for 3 months. So history of presenting illness, pain and swelling of joints, which was increased in intensity for past 2 weeks. It was non-migratory and it was associated with the difficulty in walking and restriction of movements. Fever was initially high grade. He have fever for every 2 weeks and he is afebrile for 1 week or 2 weeks. He was treated in a nearby hospital. Then he is presented to us with the fever for low grade for past 1 week. It was intermittent, not associated with the chills, trigger, and rash, and interfebrile period was active. There was no history of rash or oral ulcers. There was no history of sore throat, no history of early morning stiffness, no history of decrease in vision or redness of eyes, no history of low backache, no history of burning micturition, no history of nocturnal awakening due to pain, no history of loose stools, abdominal pain, hematuria, and there is no history of loss of weight and appetite to rule out other causes.
Go ahead, please.
Clinical, there was a Pallar plus, there was a significant lymphadenopathy, left cervical, posterior cervical lymph node, and right inguinal lymph node of size 2 × 2 centimeter, which was tender. On P-Gall's examination, gait was limping gait. Arms and legs, the movement was affected and spine was normal. Local examination of both knees, ankle, and hand joints, there was a swelling, warmth, and tenderness, and there was restriction of movements plus, suggestive of arthritis. And other system was normal with abdomen showing a spleen tip. Coming on to investigation.
Dr. Karthi, can you just take a pause here because we've been hearing this word again and again, P-Gals. Would I request Dr. Suma to very briefly tell us what P-Gals implies? Is it a good screening tool? Does it have any specificity for a disease, or is it just a good way to screen this child rapidly in a busy OP practice? Dr. Suma.
Yes, P-Gals is an excellent way to screen a child rapidly in a busy OP practice to see whether there is any problem with the musculoskeletal system. It does not diagnose JIA, but it will, if you follow the process that P-Gals takes you through, you will be able to see whether there is, it can pick up myositis, it can pick up arthritis, it can pick up, asymmetrical unilateral significant arthralgias, and pick up any number of problems actually that you need to go back and re-examine that site and validate your findings. At the same time, if you do a P-Gals and it's completely normal, you're probably ruled out a possibility of a musculoskeletal illness. So that's where it really helps you to screen out patients and to pick out those patients for whom you need to go back and examine the regions in more detail to pick up the specific findings.
Thank you.
Okay.
Dr. Karthi.
Okay, sir. On
Madam, excuse me. Before going to the investigations, madam, your differential diagnosis in this patient, madam. Suma, madam.
My first diagnosis in this patient is systemic JIA. Because he says the child is having regular fever, is clearly showing that the child has a polyarthritis. It's been going on for 3 months. It is progressing in its in the course.
Dr. Suma, you told us
Yeah.
about the musculoskeletal manifestations of brucellosis. We are heavy into cow's milk, pasteurized, unpasteurized, directly udder in any form. Can you please elaborate on the musculoskeletal manifestation? When do we as clinicians suspect brucellosis?
So brucellosis, usually a PUO, one of the situations when you have a PUO and you have musculoskeletal features to go with it. So again, the nature of fever in brucellosis is usually not a continuous fever. It can be a quotidian kind of fever also that you see in systemic JIA. It's unusual that they have very high, they can have high spiking continuous fevers, but that is less common compared to the quotidian type of fever.
They have arthralgia or yes?
They can have arthralgia more commonly than arthritis. They can have actually sacroiliitis can be a feature. They can even have spinal lesions in brucellosis. And the spleen tip is here is one of the things that you can think of brucellosis here. But to be honest, there are so many inflammatory conditions in which you can see some hepatosplenomegaly that is not going to be specific for any particular thing. But a polyarthritis in brucellosis is not common. It is reported, but it is not common.
Can tuberculosis be considered in a chronic history in a country, the Ponsets type of presentation?
Ponsets arthritis usually is an oligoarticular symmetric arthritis. Tubercular arthritis, musculoskeletal tuberculosis is basically the commonest presentation is like a reactive arthritis, like a Ponset, where you have a symmetric oligoarthritis most of the time. You can have polyarticular involvement in TB arthritis as well. You can have multifocal arthritis in tuberculosis as well. It is less common. And you can have osteoarticular tuberculosis, where usually a single joint or a single bone with an osteomyelitis is involved. And so that can be another presentation of tuberculosis. For osteoarticular tuberculosis to evolve, the tuberculosis process should have been going on for a period of time, because in the lifeline of tuberculosis, if you see, tubercular infection, it takes several months for that kind of a process to evolve.
So in this case scenario that Dr. Karthik is present, would you consider acute lymphoblastic leukemia, neuroblastoma, tuberculosis?
No.
Why not?
I think infections would still be a differential diagnosis. Malignancy would not. The kind of symptoms that the child is presented with, malignancy is not in the differential diagnosis here. This child is not that kind of nocturnal pain. The child has clear arthritis here in this case. Usually, the malignant patients tend to have more of periarthritis or bone pain.
Perfect.
This child has clear arthritis. So malignancy is very low on. Lymphoma is something you have to think about in somebody with a PUO and lymphadenopathy, a spleen tip, but it's very unusual for lymphoma to have overt arthritis. They can have arthralgia, they can have bone pain, they can have night pain, but overt polyarthritis like he has presented is unusual. Brucellosis is a good possibility in this case. Even TB you have to consider when you're investigating the patient, but the kind of thing he has presented is, I have to see whether there's deformities. I would like to see photographs actually. That would really tell me what is happening, but definitely systemic JIA is to be kept in mind. Systemic JIA is a diagnosis of exclusion. So obviously it means that in your investigative process, you have to think about these differentials too.
Why not polyarticular JIA, madam, even though the age is not in favor? Why not
No, he has presented
JIA?
he is presenting a history of fever, no?
Fever.
A regular fever, a quotidian fever. Yes, sometimes polyarticular JIA can also have some fever and systemic features at the onset. The other diagnosis I would keep in mind is also Crohn's disease, inflammatory bowel disease, that can present with fever. Usually it presents with lower limb arthritis more than a overt polyarthritis. But this kind of thing, a child who has a progressive inflammatory process with some fever, loss of weight, and an arthritis, another differential is IBD. And children rarely have bowel symptoms at the point of diagnosis. It's usually failure to thrive and chronic inflammation that make you think of the diagnosis.
Thank you. Thank you. Dr. Karthik, can you proceed and wrap up your patient?
Okay. Hemoglobin was 8.5 gram per deciliter. Peripheral smear showed a normocytic normochromic anemia, and CRP and ESR was high. And we did a ANO, ANA by immunofluorescence, which was negative. ASO, RF factor was negative. After examination showed no evidence of uveitis. Echo for pericardial effusion, which was we did echo for pericardial effusion, which was normal. This is a chronic process for more than 3 months. We think of malignancy, so we did a bone marrow aspirate, which was normal. This is a X-ray picture. There was no evidence of osteopenia. Actually, X-ray was normal. So we think of rheumatological condition, commonly juvenile idiopathic arthritis, and hematological, we think of acute lymphoblastic leukemia. So final diagnosis is child had a fever for more than 2 weeks, arthritis involving more than 4 joints, generalized lymphadenopathy, and there is a splenomegaly. So we think of systemic onset juvenile idiopathic arthritis. So we started on tablet prednisolone, NSAIDs, and DMARDs for systemic onset JAA. Child showed a dramatic response in 48 hours after initiation of steroids and methotrexate. Pain and swelling was subsided, and child was currently on rheumatologist follow-up. Thank you, sir.
Can I just ask if this child is under a pediatric rheumatologist?
No,
Please make sure these children are under pediatric rheumatology.
Okay,
Yeah, 5 milligram. What's the weight of the child?
Weight 24 kg, ma'am.
5 milligram is a ridiculous dose.
Okay.
Completely ridiculous dose to use. And this child is not going to go into remission or proper arthritis treatment on that kind of dose. The treatment has to be very, very upfront, DMARD use of the right dose, right aggression is extremely important. And these patients need to be, and there is a lot of difference between adult rheumatology and pediatric rheumatology. This kind of child really needs a pediatric rheumatologist. If Coimbatore Road, you have Dr. Mahesh coming regularly, you can get him.
And mass is also very common. Mass is very common also, madam.
Yes.
Mass is also very common.
Yes.
Dr. Karthik is presenting from Trichy, so I'm sure he would make the attempt to get in touch with him.
Yeah, sure, sir.
Right. Point is well
Please
taken.
do. Yes.
Ma'am, very briefly, when would you want us to refer children with musculoskeletal or joint to uveitis for a uveitis screen, ma'am? What is the role?
So all cases, any patient suspected to have JIA should have a screen by an ophthalmologist for uveitis. The incidence of uveitis, so there is 2 kinds of uveitis. You have chronic anterior uveitis and you have acute anterior uveitis. So chronic anterior uveitis is seen more in the younger children who present with either oligo or polyarticular JIA, and often these children can be ANA positive as well. And these children will not have any symptoms. 1, they are very young to report them, and 2, the disease itself is asymptomatic in the early phase. And if you wait for symptoms to happen, usually the disease has progressed and complications like cataract have already set in, or BSK. So the important thing is that uveitis is a preventable cause of blindness in children. And systemic therapy has to be started very, very early. So to catch them early, any patient you suspect with JIA should be sent for a uveitis screen. The incidence of chronic anterior uveitis is lower in patients who present with enthesitis related or systemic JIA. But even those patients should be screened. Generally, patients with enthesitis related arthritis tend to have acute uveitis, which is very painful, very symptomatic, and will always come to attention. But even then, it is a blanket rule that every patient with JIA should be screened by the ophthalmologist and should undergo repeated screening every 6 months, or in an oligo JIA a little more frequently than that.
One last question. What is the role of radiology in the management or diagnosis of patients with JIA? Do we want to wait till changes appear radiologically, or is it a clinical lab investigation?
It is difficult to diagnose that radiologically, sir. If some child comes with the knee joint, ultrasound shows mild effusion or transient synovitis only. Without a clinician, that clinician suspicion, the appropriate investigation, JIA won't be diagnosed. We can tell mild arthritis is there, mild synovitis is there, but to put it into that dwelling, JIA, it's a clinician work.
Okay, thank you.
But my radiologist is indispensable for me.
We understand that intelligence will always be in demand. Okay. Any parting comments? If there are no questions, I take this opportunity to thank each and every presenter.
1 minute, Ashwath. 1 minute, 1 minute, Ashwath. 1 minute, Ashwath. Dr. Lenin, hello. Lenin is here?
Yeah, I can hear it, Dr. Pallirav.
Yeah, for the practice, for the sake of practicing pediatricians, unilateral limb, whether painless or painful, three conditions in different age group for to carry out.
Okay.
To carry home.
Initially, at the start of this presentation, or the start of this talk, I was talking about 0 to 5 years, 5 to 10 years, and more than 10 years. So 0 to 5 years, the most commonest cause for a limp or a painful limp is transient synovitis or septic arthritis. So we have Koch's criteria to separate transient synovitis from septic arthritis. On top of it, fracture or trauma is something that we have to keep in mind at all age groups. Okay. And between 5 to 10 years, the most commonest cause that from the orthopedic point of view of a limping child is Perthes disease. But because of the unique blood supply of the femoral head between the ages of 4 and 8, a kid coming with a limp between the ages of 5 and 10, we have to rule out Perthes disease, because the implications of that is left untreated or if not undiagnosed, they may actually go on for arthritis of the hip joint, and that may actually need a hip replacement or something drastic at a later date. And beyond the age of 10 years with a limp, painful limp, skiffy or slipped capital femoral epiphysis is the top on the list. So infection and trauma, any age group, but there are specific conditions like Perthes between the age of 5 and 10, and beyond the age of 10, it is slipped epiphysis that we are actually looking at. We have to look into it.
Thank you, Lenin.
Just ask one thing.
Yeah. Thank you, sir.
MSV is asking, sir. MSV is asking some question. MSV.
Level is chronic and multifocal osteomyelitis. I just want to know, do you have to rule out in this sort of scenarios immune deficiencies?
No, sir. No. In children who are very young with CRMO, I have 3 children very young with CRMO with something called Majid syndrome or autoinflammatory disease. And so children under 5 with multifocal CRMO, often they will have blood dyscrasias as well. They'll require transfusions or they'll have some other marrow related changes. Those patients definitely need to be screened for autoinflammatory disorders. But the other important thing is you have to be sure about your diagnosis of CRMO, because we've had a couple of patients referred to us as CRMO who were not CRMO, but who were Erdheim-Chester variant of histiocytosis.
Thank you.
Yeah,
So
thank you,
those are more of diaphyseal disease and not metaphyseal disease.
Well, I have to emphasize one point. When examining children beyond the age of 10 years, 30% of the children with skiffy or slipped femoral epiphysis presents with isolated knee pain. Isolated, but they come only with, I have seen patients here coming with an MRI scan of the knee joint, repeated x-rays of the knee joint without examining or even taking an x-ray of the hip joint. Your examination is incomplete if you don't examine the hip, because the implications of missing a slip epiphysis will be very, very serious as the head goes in for avascular necrosis and the kid ending up with arthritis. So up to 30% of the children, it has been well documented in literature, they present with isolated knee pain because the same nerves that cross the hip joint, including the obturator nerve, femoral and the sciatic nerve, all the 3 nerves that cross the hip joint, it supplies the knee joint as well. So examination is incomplete without examining the hip joint. Okay.
Yeah, thank you, sir. Really, it's a wonderful presentation. Already now 10 o'clock, 10:08. Yeah, Kannan, please.
Yeah, that CRMO actually that MR, its involvement is the metaphyseal or metaphyseal equivalent. So if child come with metaphyseal or metaphyseal equivalent edema or the clavicle involvement, that are the characteristics for CRMO. So that time we need to go for whole body MRs. Another one is that psoas abscess actually hip flexed, the child won't extend the hip, need to see for the psoas abscess, and we need to must write that, otherwise general radiologists won't see that actually that psoas abscess. And psoas abscess, the MR lumbar thoracic spine also important.
Yeah, thank you. And it's a really wonderful presentation by all the presenters. And because
Bas,
of
ஒரே ஒரு
IAPTNSE
இது கேட்டுறேன் பாஸ், ஒரே ஒரு மேடம் சுமா மேடம், ஹலோ.
Yeah. Yes.
This CRMO you told that is a total MRI you told, whether it is a disease in evolution or when the disease presents itself, when you do the whole body MRI, you will be able to pick it up.
We always do a whole body MRI at the point of diagnosis, because that can modify the way we manage the patient and also tells us what is the extent of involvement in that patient. So there are a good number of patients who will actually require pamidronate, because while NSAID can initially help, when you start weaning them, they start becoming symptomatic. So you give them pamidronate anyway. But if you have spinal lesions, you have to follow through and make sure they got healed. Otherwise,
if in your series, if they would have presented with a localized presentation, whether they were having generalized findings in the MRI.
So that is the important thing, is that you can have silent lesions. So like this patient that was presented had ankle related symptoms. So all her symptoms are related to the around the ankle, but she had so many lesions when they did the whole body MR. They found many lesions from pelvis downwards. So that's why it's important to do a whole body MRI in these patients. They don't do they do specific what do you call, specific cuts to look for that.
They'll do a screen.
Yeah,
thank you, madam. Thank you very much, madam. Thank you, lady.
On behalf of IAPTNSE, I am really thankful to all the today's presenters, and as well as today's experts like Dr. Lenin Babu and Dr. Suma Balan and Dr. So all the other persons, and really it's a wonderful presentation by everybody. And I would like to ask Dr. Aswath, please. Dr. Aswath, comment.
I just want to say good night and a very, very big thanks from the bottom of my heart to all the experts who's taken. It's been 2 hours and 11 minutes. They've been very patient with our queries.
Video on pandra day. Video motha kamida.
So we have been very, very fortunate to have such an enlightened panel to help us out. Thank you once again, and wish you all a good night.
I thank everybody, and I thank Dr. Lenin and Suma, Dr. Sangeeta, and Dr. Kannan, and I thank our president, dynamic president, Dr. Suresh Palanji, and who has helped us to make this possible. And I thank our honorary secretary, Dr. Thirumurugan, and I request our Thirumurugan to tell a lot of thanks, please.
Thank you very much. I think we have stayed too long, so let's conclude by saying thanks for everybody, including the panelists and the organizers and all the presenters, and last but not the least, our attendees. So thank you very much, and hope to see you again next program at the last week of March. Thank you. Bye.
Suresh Palan, sir.
Thank you.
Thank you, sir. Good night. Well done.